Good morning, good afternoon, good evening. This is just a real honor and pleasure to be able to introduce to you this second day of the third module of the WEMP's Hippocrates meeting on the brain. And I want to congratulate Dr. Linda DeVries and Luca Romangi for putting together this outstanding program. Yesterday, we had a fantastic lecture by Pierre Gressens on what makes white matter so vulnerable. Today, Linda DeVries is going to talk about imaging and early outcomes of white matter injury. And I'm very pleased to say that yesterday we had close to 400 online registrants and over 2,900 registrants who will sometime be able to access these lectures. So thank you very much for being a part of this. And I'd like to give this over to Luca, who is going to introduce this today's meeting, and also Linda DeVries.
Thank you, Joseph, so much for this consideration. And just to carry on, just to let people know how our mind is changing, it's a pleasure to see the number of attending people going up second by second. And so we will give time to these people to join, and there is no competition between talks, but what to say about, first of all, the next speaker, Linda DeVries. Okay, so I'm not sure I can arrange an introduction at the level of her value, honestly. So I'm a bit, how to say, shy to say what really I think, because each people involved in neonatal neurology is so keen to listen and to learn from Linda since ages. For this reason, and even for many other reasons, she has been appointed since a while as a professor of neonatal neurology. And I don't think there is a better opportunity or definition to give you the exact mission she has got. So we are extremely fond of her value, of her teaching, of her papers, of her talks. And I love to have something to share. She's been introduced to ultrasound, if I remember well, when she was attending London brain ultrasound. I'm speaking, you know, she has produced not only paper, but a fantastic book that is a sort of worldwide guide for people who are not only introducing themselves to ultrasound, but learning and learning day by day. And she was introduced to ultrasound by Malcolm Levine, that I had as a mentor as well, and I like to give you his name in this opportunity. And so Linda has produced something like 470 papers. And making a joke, I asked her, how many are not of neonatal neurology? And she was very proud to say none. It is my pleasure, but it's not so difficult to understand. It will be the pleasure of many people now listening to her talk. Linda, sorry if I wasn't enough correct to introduce your great experience and value in this field for all of us.
Well, thank you very much for these very kind words, Luca. I really appreciate it. And I also very much appreciate Professor Moretti and Dr. Professor Neu for giving us the opportunity to organize these webinars. And this webinar, as you heard already yesterday, is on white matter injury, a very important topic for our preterm population. And today it's my pleasure to talk about white matter injury, how to diagnose it, and look at early outcome. And yesterday we had a great talk by Pierre Gressens about the vulnerability of the white matter. And tomorrow we are going to listen to Professor Neil Marlowe talking about long-term outcome. But today it's all about imaging, and I do this on behalf of many colleagues, both from the University of Utrecht as well as the University in Leiden. So today we will talk about the role of cranial ultrasound and MRI for the diagnosis and also for the prediction of early neurodevelopmental outcome. We're going back to France because also the term PVL, which literally in Greek means leukos, white, and Malaysia, softening of the white matter, was coined in Paris by Jean-Claude Laroche in 1962. And Pierre also showed this pathology specimen yesterday. And these lesions in the early days consisted of coagulation necrosis of the white matter. So there were really holes in the white matter due to this necrosis. And then in the early 80s, when I was spending time with Malcolm Levine in London, it was very exciting and also very sad that we could see these cysts in the white matter on ultrasound. And you see an example here in the old days, in the early 80s, where the cysts are so-called honeycomb appearance and they're separate from the white matter, but there is some ex vecchio dilatation due to loss of white matter. Fortunately, over the last couple of decades, the diagnosis is less often made, and this is a very positive thing because it's the main predictor of later cerebral palsy. So when we started to see these lesions on ultrasound, we came up with a classification, which is now very old, in 1992. And we said it always starts with echogenicity in the white matter. And then you have to repeat your ultrasound to see what happens to these areas of increased echogenicity. Are they persisting beyond 7 days? Then it's a grade 1. Are they evolving into small focal cysts? Then it's a grade 2. Are they really extensive and involving especially the parietal lobe? It's a grade 3. And if they extend into the subcortical white matter, then we would tend to call them a grade 4. Fortunately, as I mentioned, it's coming down, and this is Ingelotte van Haastert, our physiotherapist who did a PhD on this, and she looked from the early 90s up to 2005 and was able to show that in blue, the extensive cystic PL grade 3 was coming down considerably and significantly over this period. So moving from grade 3 to, if we still saw cysts, to a grade 2. And it was not only that this was important, it was especially important that the level of spasticity as measured with the gross motor function classification system was also coming down over this period. So in blue, we see the severely affected children who are mostly wheelchair bound and cannot walk unaided. And in the last period, we see that most of them have level 1 to 2, so they can walk unaided, but they sometimes may need some more assistance when they are walking for a longer period of time. So this was especially important for these children. And also when we extend this period up to 2013, then we see that the decline continues. And not only for the cystic PVL, but this was coinciding with the rate of cerebral palsy from over 6% to less than 2% in the last period. So very positive information. We see here an old paper by Betty Ford from 2005 looking at the neurodevelopmental outcome, and we can see that the odds ratio for a cystic PVL for neurodevelopmental impairment is by far the highest for cystic PVL, even compared to a grade 3 to 4 IVH or the use of postnatal steroids or the presence of bronchopulmonary dysplasia. So really by far the most important risk factor. And this was recently last year confirmed by Campbell and others in Journal of Pediatrics, looking at white matter disease. And they defined this as the presence of either parenchymal ecolucency or moderate to severe ventriculomegaly. And we can see here that the white matter disease without associated IVH was associated with an increased risk of cognitive impairment, cerebral palsy, and development of postneonatal epilepsy. So when we talk about cystic PVL, can we diagnose it with ultrasound? Yes, we can. These extensive cysts in the white matter can easily be recognized as long as ultrasound is repeated for the first couple of weeks at least. So here we see a typical example of a child who developed severe cystic PVL grade 3. And we can see on the left that the echogenicity in the white matter is very inhomogeneous or patchy, and it extends also a bit in the deep white matter. And if these children are stable enough and you can perform ultrasound as well as MRI, then you can, in the first week after the onset of the injury, see the diffusion abnormalities. And here we would say that these diffusion changes are kind of confluent because they are so extensive. And if you see this, then you're pretty certain that the child is going to evolve cystic lesions in the white matter. And we can see here as well the involvement of the cortical spinal tracts and also lower down in the cerebral peduncles, very predictive of subsequent cerebral palsy. At term equivalent age, we still see the cyst in the white matter, and we also see that there's no real myelination in the posterior limb of the internal capsule, and the thalami also look quite small. So not surprisingly, this child didn't do well at 5 years at very high level on the GMFCS, cerebral visual impairment, post-neonatal epilepsy, and interesting as well, this child didn't develop any speech, which fortunately is not very often the case. Here another example, a little boy who was born abroad and then developed a pneumonia. And we know from yesterday's talk that inflammation is very important and a real risk factor for developing white matter injury. So following this pneumonia, he developed these lesions. And as they are usually seen, they are bilateral, not always entirely symmetrical. And at term equivalent age, they already are a little bit in regression. The cyst eventually will disappear. We do not see nice myelination once again at term equivalent age. And at 2 years, we no longer see cyst, but we see decreased myelination, exvacuodilatation of the ventricles. And if you would do another sequence, you would also find periventricular gliosis. So extensive white matter cysts are kind of easy to recognize. They usually take 2 to 3 weeks to develop. And the cysts are often still present by term equivalent age. And if not, then we will see irregular ventriculomegaly and also some early gliosis with the MRI especially. And most of these infants will develop cerebral palsy and have a GMFCS level 3 to 5. But over the years, we have seen that these cysts are now quite uncommon. We sometimes see a few focal cysts in the white matter, but most often we see children who have diffuse white matter signal intensity abnormalities or these so-called punctate white matter lesions that will not evolve into cysts. So this was beautifully reported, as always, by Volpi together here with Quaya in 2008. And these drawings very clearly show that we have moved from cystic PVL, which was easy to recognize with ultrasound, to diffuse white matter abnormalities that are non-cystic, diffuse white matter gliosis. And on ultrasound, we see some increased echogenicity, but it's difficult because that is rather subjective and not at all objective, like the cyst we can see so clearly with ultrasound. So let's move from the extensive cyst to the focal cystic white matter injury. And for this, we really need longer serial cranial ultrasound because these cysts take longer to develop. So here we see an example of one of these cases, and we can see on the left, on the top, that there is severe inhomogeneous echogenicity. There are some kind of separate foci throughout the white matter. There's also a germinal matrix hemorrhage. And as the child was stable enough to be transferred to the MR unit, an early MRI was performed. And on this T2 sequence, we can confirm the hemorrhage. And we also see the white matter abnormalities with a low signal. So in this case, the lesions were hemorrhagic in the white matter. And then 4 weeks later, we can see the cysts bilaterally, but they're very focal, and we also can still see the germinal matrix hemorrhage evolving. The baby came back at term equivalent age, and at this stage, the cysts were no longer present. but we did see these punctate lesions in the white matter. And interestingly enough, you can also see them with high quality ultrasound over here in the same site. And here on the axial plane, we see them here posterior to the occipital horns of the lateral ventricle. And there seems to be adequate myelination of the posterior limb of the internal capsule. And so far, this child has been doing well at the age of 12 months corrected age. But if you would only have had your term equivalent age MRI, you would have classified this child as a child with punctate white matter lesions. So it's always very good to have the two techniques together, serial ultrasound, up to the time that you may expect cysts to develop. And again, the term equivalent age MRI, which will allow you to also look at myelination and the late results of the initial injury. Here we see an example where the baby was rather uncomplicated, 31 weeks, had an early discharge, but there was some echogenicity on ultrasound. And at term equivalent age, the child came back, had an ultrasound and an MRI, and we can again see these punctate lesions in the white matter. But here we do see that they seem to be crossing the cortical spinal tracts, and this child did develop cerebral palsy. Now, if you look at the images that were made in the local hospital, we can see that indeed some cysts did develop, and they had already disappeared again at term equivalent age. So very important to work together between the level 3 and level 2 hospital, and they will continue to perform the ultrasound to identify these cystic lesions. Why did this baby develop the cystic PVL? Well, it definitely did have quite a few risk factors. We see that the baby had decreased fetal movements. The mom had preeclampsia. There was a poor CTG, which led to an emergency C-section. And we can see postnatally that the child had hypocarbia, which is known to lead to vasoconstriction and has been reported to be a risk factor. If we look at this recent study, which I think is very interesting, from the group of Claudia Roll in Germany, they looked at spontaneous hypocarbia in children who did not get mechanical ventilation. And we see here that there were quite a number of children of their 21 cases with cystic PVL who had a CO2 below 35. And we can see that 33% of these children were infants who did not receive any respiratory support. So probably they were hyperventilating because of their neurological problem. And many of these children never get admitted to a neonatal intensive care unit and are in the local hospital, like this case from Utrecht, with very, very severe cystic PVL. So even in the other hospitals, ultrasound is very important to be performed. So the focal white matter cysts take longer to develop, 4 to 6 weeks. They may often disappear before the child is reaching term equivalent age. We then see irregular ventriculomegaly and sometimes these punctate lesions in the white matter. And I think that when you only take term equivalent age MRI into account, the presence of punctate white matter lesions has been associated with a considerable risk for development of cerebral palsy. But this may actually be due to the fact that the cysts were missed. And this might be an example. It's a very nice paper from Sabina Council's group. And at the top, we see punctate lesions in the white matter that are quite extensive. There's quite some irregular ventriculomegaly. And this child may or may not have developed cerebral palsy, but it could well be that cyst had preceded these extensive punctate white matter lesions. And one of the reasons why I say this is that there are quite a number of children who have more than the level 1 GMFCS, and even 2 had level 3 GMFCS, which is more severe than you would expect for punctate white matter lesions. So here is another child who looked very extensive, really a grade 3. And this was confirmed on the early MRI after a couple of weeks at this stage. And again, at term equivalent age, we do not see any clear cyst anymore. Maybe there's a single one over here. And we see quite a bit of gliosis, especially on the right side. So if you look at the Kido-Koro score and how they defined periventricular leukomalacia, white matter injury, then the child at term equivalent age would have qualified as a grade 3. But if you take the earlier MRI into account, then the child would have been classified as a grade 4 PVL white matter injury. So again, it's important to have these sequential imaging, whether it's ultrasound or MRI, and preferably both. Group in the States, Sarkar, published data in 2015 also stressing this issue. And here, 14% of a large number of cases with cystic PVL were no longer showing these cysts on the 36 weeks ultrasound. And of course, understandable, if you were more mature at delivery, then it took longer before you reached 36 weeks postmenstrual age. And there were especially more children who were very immature, who lost their cyst, so to speak, by this 36 weeks or term equivalent age. They then went on to look whether if you did not have any cysts anymore at term equivalent age, whether your outcome was better. But of course, this was not the case because the injury had been there, and these children were also significantly at risk of a poor outcome, neurodevelopmental impairment. So let's talk about the more complicated imaging for non-cystic white matter injury, and these children are more difficult to diagnose reliably, as we will see. So echogenicity in the white matter may look quite okay, and we then tend to call it a blush. It's there, it's a little bit, but it disappears after a couple of days. It may be more serious if it's patchy, inhomogeneous, and if it's there for longer than 7 days. And it's really serious if it's really more echogenic than the choroid plexus, and it looks really irregular, like the example here on the right. So in the early part of this century, there were several studies comparing ultrasound and MRI. And we can see that the echogenicity on ultrasound didn't really predict the abnormalities in the white matter on MRI very well. But 2 studies where the ultrasound was repeated beyond the first week, the sensitivity was around 90%, in contrast to 40 to 50% in the other studies. Here's an example to show you that it might be quite difficult. A child where there is some echogenicity, and if you look on day 18, it's a little bit more prominent on the right than on the left side, but it doesn't look very serious maybe. But then the child did develop a mild hemiplegia, and an MRI at 18 months was performed. And we can see the irregular shape on the right and some periventricular gliosis. So probably we missed some focal cysts in this child that had appeared after discharge on day 18. So can we improve and make this diagnosis of white matter injury more reliable? Yes, I think we can if we are using MRI. So if you have a possibility to perform the MRI during the first week or the first week after the presumed time of the insult, then we can see that diffusion weighted imaging is really helpful. On the left, we see that there is one lesion in the white matter that made us very suspicious, but it's no longer showing diffusion restriction, but there are many other lesions which are punctate in the white matter. In the middle case, it's a little bit more prominent even, and we see that there are a lot of punctate lesions on the diffusion, and some are a little bit more confluent, which are a marker for potential cystic evolution. And this one I already showed you, very severe, very confluent, and you are quite convinced the child will develop cyst. So here's an example of a child who developed a staph epidermidis septicemia on day 10. We see the echogenicity after the sepsis. It's more pronounced on the right side. We see that the diffusion is very confluent on the right side with just a few punctate lesions on the left side. And then, as predicted, there are cysts appearing both on ultrasound as well as on MRI. Unfortunately for this child, it was predominantly on the right side. And we can see here at 2 years of age on a repeat MRI that this ventricle is larger, it's irregular in shape, and there's a lot of loss of white matter with the sulci abutting the ventricular wall. And due to the predominant unilateral injury, this child was able to walk and had a GMFCS level 2. So if you are looking at these lesions in the white matter, you would like to know whether they're ischemic or hemorrhagic in nature. And you can do this by combining diffusion weighted imaging. As we see over here, there is diffusion restriction. But if you look at a sequence called the susceptibility weighted imaging, where hemorrhage is seen as low signal intensity, you do not see any abnormalities in the white matter. So in this case, you could say it's ischemic in nature. So Nienke Wagenaar went to work a little bit with Stephen Miller in Toronto, and we compared 2 cohorts from Utrecht and Vancouver, and we can see that the children who were having a high risk to develop punctate white matter lesions were related to the center where they were born, when their birth weight was greater, what they had associated IVH as well. Then recently, Stephen Miller and his group had an interesting paper looking at these punctate white matter lesions with a simple white matter imaging rule, as they say themselves. And they drew a line at the curvature of the lateral ventricles. And the punctate lesions, which are posterior to this line, didn't seem to matter so much, not relate to the outcome on the WIPC or the movement ABC at 4.5 years. But if they also crossed this line, then the children were having issues at the age of 4.5 years. So this is easy imaging rule to be used. In the past, we also talked about DESI, which was diffuse white matter signal intensity changes, but these actually did not relate very well to outcome. And these are no longer kind of referred to in the literature. And now it's more about punctate white matter lesions. But the group in Lausanne did an interesting study where they measured the ADC values in the white matter and also in the posterior limb of the internal capsule. And they then went on to do a follow-up of these children, looking for transient tone abnormalities at 6 months, and then to see whether these transient tone abnormalities related to outcome at 18 months. And they did indeed see that the children who had transient tone abnormalities had higher ADC values in the white matter, meaning that the white matter is wet, it's high signal intensity. They had lower fractional anisotropy values in the posterior limb. And if they did have this, they have significantly lower motor scores on the Bailey at the age of 18 months. So if you talk about white matter injury, it's important to forget, not to forget that there can be other underlying problems, like a late onset septicemia, or especially necrotizing enterocolitis, CSVT, sinovenous thrombosis, neonatal surgery, or a viral encephalitis. So if we look at a child over here who was born at 24 weeks and then had an MRI at 30 weeks, as was routinely performed in Utrecht, we can see that there are no overt lesions. And so we thought the child was doing well and was kind of very lucky to have this nice MRI. However, 2 days later, after the MRI, she developed severe necrotizing enterocolitis, was very ill during surgery, hypotensive, and almost died. And 2 weeks later, she had, unfortunately, this cystic PVL, which you could refer to as late onset cystic PVL. She has very extensive cysts confirmed on the MRI a week later. And at term equivalent age, we can still see the cyst. And we also see the asymmetry of the posterior limb of the internal capsule being better on the right than on the left. So her cerebral palsy was asymmetrical. And at 20 months, again, the cysts have gone. There is loss of white matter, irregular ventriculomegaly, and a very poor performance on her WIPC at 6 years, both on the total IQ, but also on the verbal IQ as well. Another example, following sinovenous thrombosis, a child who came in after having been initially quite well in our unit and then being readmitted with a very low sodium, which turned out to be to a renal artery thrombosis. And on admission, we saw that there was some clot in the superior sagittal sinus without any flow there. And the MRI shows a large thrombus in the superior sagittal sinus, as well as the straight sinus. And on the diffusion, the entire white matter shows diffusion restriction. And subsequent to this, we see extensive cystic evolution. So if you would just look at the ultrasound and the MRI, you would say this child has got cystic PVL, but of course it's also important to know the underlying problem, which here was CSVT. Then PhD student Nathalie Klaassen looked at the cardiac babies, and we know that they very often pre and especially post-surgery develop these punctate white matter lesions. And the same applies to the non-cardiac surgical babies. And this is Lisanne Stolweg, another PhD student who showed this in both preterm as well as full-term infants. After surgery, we saw a lot of punctate white matter lesions. And then the encephalitis, this is a baby with rotavirus infection who got readmitted and initially had normal ultrasound, but immediately after having been so sick, showed a lot of injury to the white matter with cystic evolution 2 weeks later and very extensive cysts throughout the white matter on MRI at the same time. And again, no longer any cysts, but very severe atrophy and gliosis at 2 years of age, and a very poor outcome with also hypsarrhythmia and severe epilepsy and severe developmental delay. So the white matter is very vulnerable in these infections with different viruses, also entero and parkechovirus. And then finally, an example of a grade 4 after losing a co-twin due to TTTS. And we see here the same day ultrasound and MRI, and the difference, the way it looks is very impressive, because here at least you think there is still some tissue remaining, but here we can see that only the cerebellum kind of survived this severe insult. An interesting paper recently was a paper by Reddy and colleagues looking at PVL mimics. And here is a mimic due to COL4A1 mutation, which is having an increasingly wider spectrum of the types of injury. So it looks very much like PVL. There's a little bump here, which may have been a hemorrhage as well. But anyway, the child had COL4A1 mutation of the collagen gene. And this is another example, the pontocerebellar hypoplasia type 9, which in Leiden was recently also diagnosed antenatally. And in the supratentorial region, we see it looks very much like PVL, but of course we do not expect with PVL to see this degree of cerebellar hypoplasia. So a very interesting paper with a lot of interesting examples. So I showed you this classification system, which was reported in 1992, but more recently in 2020, Thijs Aykut and colleagues had this nice paper on a new classification system, also taking the white matter volume assessment at term equivalent age into account. And I think that is also very important. So it's a very good addition to the literature. Together with a group of Francis Cowan and Mirjam Martinez-Biarge, we set out to have a new classification system for combining serial ultrasound and MRI. And the aim was to also be able to classify PVL white matter injury during the neonatal period. So we had 82 infants altogether, and the most numbers were the grade 1 or the grade 3. And these had at least 1 MRI, but most had 2 MRIs and also serial ultrasound. So for the grade 1, we made a distinction for 1A and 1B, whether they had more or less than 6 punctate white matter lesions. And these would initially be seen with diffusion as diffusion restriction. And at the term equivalent age, you would still see them as high signal on the T1, but otherwise the myelination of the plic was normal and there was usually no ventriculomegaly. For the grade 2, we would see the punctate lesions clearly again on the diffusion with sometimes a little bit of confluent areas, which then subsequently were seen to be cystic in the middle period. And in the late period at term equivalent age, you could or not could see the cyst still. You would look very carefully for the myelination, which looks very sparse and absent on the left side. And you would also look for gliosis and ventriculomegaly. And for the grade 3, you would take the benefit again of the diffusion during the first week, which is then very extensive and confluent. In the middle, there would be cyst, and at term, sometimes cyst, and sometimes the cyst would be gone. But then you would see a lot of ventriculomegaly and absent of the posterior limb, and also the glial scarring. And looking at the relation with 2-year outcome, you can see that the relation is very strong. CP is mainly present in the cystic lesions, and we can see that the levels 3 to 5, especially in the grade 3, and also the global DQ goes down with the level of the cystic white matter injury. So then a few examples of early neurodevelopmental outcomes. So this is a nice painting by Paula Rego from Portugal. So this is a few examples, and for those who have been watching the Newborn Brain Society lectures, these were also shown by Mehmet Cesmeci a couple of weeks ago. So here is a child who develops extensive grade 3 cystic PVL, also had an IVH and a reservoir for PHVD. And looking at the massive cysts in the white matter, we were very concerned about the child's outcome. And if you look at the video clips, then we can see that the child is having a lot of problems. It has a sacral sit. It doesn't show any kicking in the standing position. At 3 years of age, the child is scissoring and dragging his leg when he tries to crawl. And at the age of 4 years, there was severe cognitive impairment. And you can also see that his manual dexterity is problematic. And he also had severe visual impairment. So a very severe outcome in this little boy. In another example, which is quite severe, but a little bit less, we still would refer to this as a grade 3 with bilateral cysts in the white matter being extensive, but a little bit of myelination in the posterior limb at term equivalent age when the cysts were no longer seen, but still the outcome was predicted to carry cerebral palsy at least. So we see that she is able to crawl a little bit better, but still not normal at the age of 15 months. And at 2 years of age, she is able to cruise, but she does it very much while tiptoeing. And she will sit down in a minute and is doing this with the so-called double U-sit in between her legs, which is also common in children who develop cerebral palsy. And then at the age of 6 years, we can see that she is asked to walk on the line, and the video doesn't actually work. Anyway, she's able to do this, but not very well with a lot of associated hand movements. And the last example is the one we already saw the images of with focal cystic lesions in the white matter. And because of the asymmetry of the posterior limb, we expected to see more problems on the right than on the left side. So if we look at this little boy, he definitely is the best of the 3, as you would expect. Although he's not able to sit with his legs extended, he's able to crawl a little bit better than the other 2, but his feet are still kind of stuck to the floor. And when we look at him at the age of 2 years, he's able to walk, although with a wide gait, and his feet are externally rotated. And if we look at him at the age of 4 years, we can see that if he's running, that he's winging with his right arm still, but he did get a lot better over the years. So some examples here of these children. And then finally, a few words about the use of advanced MRI techniques to improve prediction of outcome in these children. And this, I think, is a very, very nice DTI-like drawing, and actually is done by the daughter of Silke Steggerda at the age of 9 years. But you can see here the corpus callosum and the internal capsule very clearly as well. So first of all, if you look at the data by Joe Volpe's group in 2007, they showed that if you have injury to the white matter, it doesn't restrict itself to the white matter, but it will also affect the deep gray nuclei especially. And you can see here that the incidence of gliosis is around 50% in the thalamus and putamen, and the globus even 60%. So very important data. And our PhD student, Carina Kersberger, went to London to work with Serena Council and combine the MRIs from Utrecht and London. And what we can see here is the lack of growth of the thalami. So early on, we do not see any significant difference for the children on their early MRI for thalamic volume. But if you look at the age of 40 weeks, then we see that there is really a significant difference. And you can already appreciate this over here, where you do not see any myelination, but you also see that the thalami look very small. Stephen Miller looked at this in a different way. He built a template of all the punctate white matter lesions in the white matter, and he then made a relation where they were in relation to subsequent outcome. So in pink, the score is less than 85. So if they were mainly in the frontal lobe, then they were, as you would expect, related to cognitive outcome. If they were also extending into the parietal lobe, then they were also related to motor outcome. So I think very interesting and nice data. And then spectroscopy, which is not often used, especially not in the preterm population. This is an interesting paper from 2019, where they looked at spectroscopy, proton spectroscopy, and they were able to show that even with the punctate white matter lesions, but especially with the grade 3, there were significant differences for the NAA choline being less than in the controls. And then finally, a study by the group of Parik looking already in 2015 as connectivity, and they found that children with moderate to severe diffuse white matter abnormalities had less well-working networks for executive control and also for the frontoparietal network. So to summarize all of this, I think white matter is the most common type of brain injury in the preterm baby. The type of injury has really changed over the years from focal necrosis to diffuse gliosis, and is less often related to severe cerebral palsy now, and more likely related to cognitive and behavioral problems later on. Neuroprotective studies have started, including IGF-1, and also nasal stem cells are still in the lab in Utrecht. And I think that careful neuroimaging is really essential, both for patient selection, but especially for the evaluation of the effect of these neuroprotective agents. So a lot of work to be done in the future, and I would really like to thank you for your kind attention.
Thank you very much, Linda. Fantastic talk, touching any aspect of the white matter potential vulnerability. In the meanwhile, we are asking people to write questions, and so we will be able to offer answer. We're just showing, according to the WEMS, Union of European Neonatal and Perinatal Societies, the meeting that will be held in Krakow at the beginning of September. Now, Linda, are you happy to try to answer the questions?
Of course.
Yeah, thank you. Alifa is asking something about white matter and contrast. If there is any help from contrast agent on MRI.
No, I think first of all, it is now recommended not to use any gadolinium during the first week in the newborn infant because it may stick to the tissue. So that's really not something we would like to do. So the answer to that is no, not using contrast. I'm sure that you will see maybe the leaking in the white matter if you're using contrast, but I would definitely not recommend it.
Yeah. Yeah, maybe some infection, no, but not adding a lot. Victoria Lima from Mexico. There are some correlation between nearest infrared spectroscopy, and this is a nice question to the Utrecht, to say, school coming from the past about NIRS, white matter and hypocarbia.
Yes.
Yeah, because I think there are, but
yes.
Please.
Yes, there are indeed a few studies looking both at hypocarbia and also hypercarbia. So you do see the changes in the near infrared. So if you have this on continuously, you may actually see that something is happening, and you may see the need to perform another blood gas to see whether your CO2 is okay, and check the baby, of course, as well. So this might be helpful. Yeah.
Yeah. From Dr. Karma from India, why blood gas? What are you regularly doing to check spontaneous hypocarbia, even if they're not on respiratory supports? And also, in case of cerebral venous thrombosis, can you give explanation about hyponatremia?
Mm-hmm. Well, yeah, for the hyponatremia, this child that was readmitted and had this very severe white matter injury due to the sinovenous thrombosis, the hyponatremia was due to the renal artery thrombosis, which was the reason why the child came back together with the hyponatremia. So I think the two there went together. But it's interesting because if you just have a child who has got low sodium, it also has got a very negative adverse effect on the white matter. So we've also, and I'm sure Luca, you as well, have seen children who have a sodium of 120, 112, and has got severe injury to the white matter.
Yeah, it's very dangerous. Yeah, I agree. And it's interesting that you mentioned, because I noticed that was a renal thrombosis, because the first baby I saw in my life, that was speaking about 1998 in Leeds, we discovered he had a venous thrombosis because of hematuria, and he had a venous thrombosis plus those lesions you were mentioning on the frontal part, coming in a late preterm baby later in life, no? So a sort of minor IVH. So I'm asking you, interesting, the renal kind of complication. Was the baby probably affected by factor II, Leiden, or things like that?
No, I don't think we found any thrombopathy.
And thrombophilia, no. That's why probably he had the arterial one.
Yeah.
That is very strange. There is another question from Ilias Chatsonadis. Is there any practical approach to estimate white matter volume for the neurodevelopmental outcome? And in the meanwhile, she's asking a question, saying, thank you for the excellent talk.
Yeah, well, there have been quite a lot of studies looking at volume in relation to outcome, and just looking at the overall volume, this relation has not been very strong. There was a lovely paper a couple of years ago by the group of Petra Huppi showing that if you look at the gestational age and sex, then it's actually predicting outcome more or less the same way as if you add the volume to it. Didn't really make any difference. But I think that if you look more specifically, for instance, at the volume of the central brain nuclei, or you look at the volume of the cerebellum, then there have been a few studies that looked at relation to outcome, which was in fact quite strong.
So you can't only blame myself for doing good, how to say, comments about you. The other question is, excellent presentation. Is a luxury to listen to Dr. De Vries. I agree. My question is, the measurement of cephalic perimeter helps with the production of clinical picture, or maybe you can tell us something about the increase of extra axial space. Do you put any value to the extra axial space? Thank you very much.
No, I don't think, if you look at children with PVL, they don't show a decline in their head circumference. I don't think the loss of the white matter is severe enough to cause this. And it's actually very interesting that if you scan a very immature baby at term equivalent age, you very often find that they have a huge extracerebral space. And then if you measure the head circumference, it's normal. And maybe it's too big for the volume that they actually have, but it's not kind of larger. And it's also not smaller because you see there's so little brain tissue remaining. So the head circumference, like in the PHVD population or preterm babies with PHVD, is not helpful. We really have to look at the brain and not just at the head circumference.
Yeah, I add my question on that because, I mean, I'd like your comment on when we were considering punctate white matter and a very nice presentation about the, how to say, heterogeneity, of the white matter. So you pointed out how they do appear, disappear, and blah, blah, blah. On your comments and final, you said, I mean, mainly also probably thinking to Stephen Miller paper, focusing on the frontal lesions, no? You say, careful, these punctate, okay, are not so bad like PVL, but if they are located mainly in the frontal part of other kind of question, asymmetry you were mentioning, things like that, they're going on a sort of cognitive kind of. And sometimes you mentioned also a couple of papers labeling before 27 weeks, before 26 weeks. So I don't know if we can assume punctate are the mildest form of white matter lesion, but apart from that, my comment is, you were saying PVL was mainly motor, and these kind of things are maybe suggesting to be more careful about cognitive. Do you think it may be also that when these poor babies had so severe PVL, where we were not so keen to assess cognitive outcome in these very disabled babies, and so we have our mind like forgetting that kind of severity of a cognitive problem of those babies?
Yeah, I think in the extensive cystic PVL, what comes first and what is easiest to diagnose. So what you're focusing on is on their motor outcome. I mean, the parents always ask, is my baby going to walk? So that's what is your focus on. But of course, we know that many of these children with severe PVL also have cognitive issues, and quite a few develop epilepsy as well. So they've got the bulk of all the problems in all domains. And these punctate white matter lesions, they may develop some milder CP when they are crossing the cortical spinal pathway, but there we seem to be focusing more on other kind of domains like learning and behavior.
So the question was, it's also a matter that we're more, how to say, sensible and sensitive to minor form of cognitive impairment. I think this is a good thing. So at the end of the day. Now there is an anonymous question from 8866143720 number, and is about Beatrice Skill paper, 2019, about term corrected age, about the cranial ultrasound score. Do you have any feeling on that?
Yeah, I'm sorry I didn't mention it, but I do think it's a nice score and certainly useful. Definitely, yeah.
And after Manish Kumar asking if neurosonogram, so it's a sort of perinatal question, can be helpful to predict outcome in severe fetal growth rate restriction. What do you think?
Well, it's interesting because these children with severe fetal growth restriction, as we know, they often do kind of better because they seem to be doing better because they don't have severe respiratory problems, and they quite often do not show very much on their cranial ultrasound, and they do have a poor outcome. An interesting study was just performed in Leiden, where they have the twin center of the Netherlands, and comparing the twin with severe fetal growth retardation with the other twin, and finding that everything in the brain is smaller, of course, in the severely growth retarded child, and these are also more viscid outcome. And so there, it's not so much as seeing the abnormalities with ultrasound, but more that everything is reduced in volume. And there, I think the MRI is going to be more helpful than the cranial ultrasound.
Right. But not so helpful either. So sometimes, no?
Yes.
To be honest.
Yes.
Sahin, because you're polite, no? So you're not like to speak badly about MRI. Thanks for the excellent talk. And after there is a question, which agent would it be appropriate during a mechanical ventilation if it is needed in terms of, I guess they mention protecting wet matter injury. Maybe if they're thinking about hypocarbia and they're asking you if we can use bicarbs for that. I don't know exactly. I'm guessing. Yeah? I'm trying to translate the question.
That's a very difficult discussion, and I remember we even once had a discussion at the Brain Club about it. If you have a child, after many beers, and then if you have a child who comes in and has a really low CO2 and a really low base success, and then you think, well, I really don't like this very low CO2 because it's going to result in vasoconstriction. Shall we give the child bicarb? And then you can say, we don't like to give it anymore anyway. But on the other hand, maybe the child, because it already has a neurological problem, that's why it's kind of hyperventilating itself. So it's a discussion that even in spite of all the beers we drank, we were not able to give the right answer.
We remain with isolated opinions, I guess. No?
But I think what is nice to see, as maybe one of the explanations why we see so much less cystic PVL, is that we do not, in the past, you know, if a child had a staph epidermidis infection and it would have apneas, it would be ventilated and the lungs were okay, and then you would hyperventilate the baby and you would have an inflammation due to the sepsis. And the hypocarbia, the child would get cystic PVL. And that has kind of gone, and because it's all kind of minimal invasive ventilation, or at least it's become a lot less. And that was also with our decrease in the incidence of cystic PVL. We looked at the risk factors, and one of the findings was that the children who had an arterial line in place were also less often showing cystic PVL. And I think that's because we could better control the CO2 levels. We were more easily aware of low CO2 levels, knowing that that's dangerous.
Yeah, this comment is opening a lot of more interesting aspects, you know, like a defensive medicine from one side, and also I still remember Steve Miller paper about making gases without producing pain, you know, and without nociception, and having microstructure abnormalities in those feeling pain. So we love medicine when it's so widely taking into account a lot of things. So again, because you have to pay this kind of fee, it was an honor to listen to your talk from Dr. Vili. And is also asking, is there a possibility of antenatal insult causing PVL? It is likely to have a better outcome given to better fetal autoregulation? Don't know.
No,
even
it definitely is possible to have an antenatal insult. We see that from time to time, and there again, ultrasound is very helpful, because if you see cysts appearing during the first week, you know that it must be of antenatal onset, because they take at least 2 weeks to develop. So that helps you a lot. And then, of course, looking at the placenta and the history as well. But it's not that they have a better outcome. I do not think so. I always think that as a neonatologist, we try to keep everything stable after birth, and before birth, you don't know what happens when a child becomes very hypotensive or anything, or has seizures. You cannot treat those either antenatally.
Thank you. Can you give me other 5 minutes to honor all the people that we touched 400? Yeah. Again, is asking someone is asking Dr. Varma, so he wasn't happy probably about your our reply. Why we did perform the gas in these babies on spontaneous hypocarbia? It can't cope with that, Dr. Varma, without any respiratory support.
And this was not our data. It was a group in Germany who did this. I don't know, and therefore I cannot answer the question.
We should invite for the beer in the Brain Club.
Yes.
Edna Solano, does feeding with breast milk make any difference in the prognosis of these babies with mitral lesion? Thank you very much for excellent talk.
Yeah, well, there was also from Germany a very interesting study where they kind of instilled, with every feed, they put in a little bit of breast milk into the nose, and they had a better outcome. They did that in children with a large grade 3 and 4 hemorrhage. So yes, maybe it could have a positive effect. I think breast milk is always good.
Yeah, exactly. The question is also why we shouldn't.
Yes.
Priya Edison, she's asking, thank you, Prof, for the excellent talk. We do not do routine MRI at term corrected age. PV flare versus grade 1 white matter. How can we be really sure of this?
Yeah, you can't. I don't think you really can. That's the problem, and that's why you would like to make it a little bit more objective by doing a term equivalent age MRI. But of course, that's open to discussion. Another hour.
Even more. Do you have any evidence on the impact of stress on the white matter injury? Natalia Charpak Kangaroo Foundation.
Well, I don't actually know. I know that with Stephen Miller, we looked at pain, which comes close to stress, and that affected the thalamic volumes.
Speaking about the lesion, she probably understood that to clarify the question after.
Yeah, and Terry Inder has looked at stress and outcome, which had a negative effect, but whether that was mediated by the white matter, I'm not actually sure. Are you?
No. But Natalia at the end said excellent talk as well. So she's very happy, despite we couldn't answer perfectly. Do you get your sonography findings confirmed from radiologists? This is a sort of dispute between us and neuroradiologists. Ashok Kumar.
Well, in the Netherlands, the neonatologists do the ultrasound themselves. So
in our country too.
Well done.
Yes. Well, to be honest, they also do, and after they ask sometimes some help at the end. Luis Ronquist, thanks for excellent talk. Linda, can we still expect diffuse white matter injury characterized by an overall hypomyelination without findings of punctate MRI lesions?
Yes, I mean, if you've got these diffuse white matter abnormalities, the signal intensity changes, so you can measure it with the apparent diffusion coefficient, see that it's higher, and as they showed in Lausanne in a nice study, it was related to outcome. But yeah, I think it's just the punctate white matter lesions are easier, and they are less subjective again. And I think that's why
we didn't discuss about punctate white matter, that maybe we underestimate them because we do not perform a lot of MRI on older babies in terms of gestational age. You know, what's your thinking about this? Is my question. It's not written there.
Yeah.
Because we may underestimate the because you saw even term babies with cardiac problems, they get it. Yeah, so what do you think about it?
Well, Stephen Miller showed that if you perform your MRI early, when the child is stable around 30 weeks or so, you see many more punctate lesions that are gone.
And maybe disappear, yeah.
So at term equivalent age, you probably underestimate. There was a nice paper in the huge group of term controls in London with Serena Council's group. And they found actually, I think in 10% that even healthy controls have the odd punctate white matter lesion. But they were not kind of widespread. There was usually 1 or 2 in the white matter, but even in healthy babies, you do sometimes see them.
Monica Morgus, that was asking questions even yesterday. She's asking something about caffeine. What do you think about caffeine as a neuroprotective agent versus white matter?
I don't know. I don't know whether that has been studied.
Maybe out of fashion recently, no? Compared to 10, 15 years ago. Is there any, and maybe it's going in a different kind of improvement more than lesions. Is there any correlation between gender and white matter injury? Asok Kumar is asking, and this is the last question.
Okay, well, that's a very interesting question. I remember that one of our PhD students, Britt van Kooij, did look at DTI and tractography and did in fact find a correlation which was just there for the girls and not for the boys. So there was definitely a difference in the development of the white matter microstructure.
Right. So I'd like to thank you. I'd like to excuse ourselves just to be 8 minutes over the 3 o'clock. And I thank you, first of all, so much, you, Linda, for this nice talk. I think it's been an extremely entertaining time. I can understand the 400 people attending, sorry. And we are just telling you, thanks again, Linda, and thank you so much. The following talk we will face tomorrow at the same time. Central Europe time, 2 p.m. Adult outcomes after extremely preterm birth, influence of neonatal brain injury, from Neil Marrow, who is the most experienced person about these long-term problems of our premature babies. So see you all tomorrow. I say also goodbye to Corrado Moretti, that was just coming at the last second of the meeting. And so we thank you also, the organizer, for this time for us. Thank you so much. See you tomorrow. Bye-bye.